Multiple sclerosis, or MS, is a neurological disorder which is chronic, progressive, degenerative, and characterized by multiple areas of demyelination from inflammatory scarring of the neurons in the brain and spinal cord. This disease can affect people of all ages. The onset is usually between 20 and 50 years old, with symptoms appearing at an average of 30 to 35 years old. The diagnosis is 2 times more likely in women than men and more common in cooler climates. Pathophysiology. While the cause of MS is unknown, it is likely the interaction of several different factors. The disease develops in genetically susceptible people that have certain environmental exposures, such as an infection, maybe a virus, or an injury. Multiple genes are believed to be involved in the inherited susceptibility. Having a first-degree relative with MS increases a person's risk of developing the disease. Other possible precipitating factors will include smoking, stress, fatigue, pregnancy, and a poor state of health. MS is characterized by chronic inflammation, demyelination, and scarring in the central nervous system. It is considered to be an autoimmune disease caused by autoreactive T cells. An environmental factor or virus in genetically susceptible individuals may initially trigger this process. The activated T cells migrate to the central nervous system, causing blood-brain disruption. This is likely the initial event in the development of MS. Subsequent antigen-antibody reaction within the central nervous system results in an inflammatory response and leads to axon demyelination. In this picture, we can see the difference of a healthy nerve cell and a nerve cell that is damaged. Demyelination occurs in irregular scattered patches throughout the central nervous system. Damage to the myelin coating around the nerve fibers and to the nerve fibers themselves interferes with the transmission of nerve signals between the brain, the spinal cord, and the rest of the body. These disrupted nerve signals cause MS, which vary from one person to another and over time for any individual, depending on when and where the damage occurs.
The onset of multiple sclerosis is often gradual, with vague symptoms occurring intermittently over months or years that do not prompt the patient to seek medical attention. Because the disease process has a spotty distribution in the CNS, clinical manifestations vary with each patient according to the areas of the CNS involved. Some patients have severe long-lasting symptoms early in the course of the disease. Others may experience only occasional and mild symptoms for several years after onset. Blurred or double vision, red-green color distortion, or even blindness in one eye may be the first symptom. Many patients describe muscle weakness in the extremities as well as problems with coordination and balance, thus affecting walking or standing. Lhermitte's sign is a transient sensory symptom described as an electric shock radiating down the spine or into the limbs with flexion of the neck. Some patients complain of pain in the low thoracic and abdominal regions. Others complain of speech impediments, tremors, and dizziness. Hearing loss is also an occasional finding. Many patients have severe fatigue, and the fatigue is often aggravated by heat, humidity, and also certain medication side effects. Bowel and bladder dysfunction can be affected if the sclerotic plaque is located in the area of the CNS that control elimination. Problems with defecation usually involve constipation rather than fecal incontinence. Urinary problems are variable. A common problem in patients with MS is a spastic bladder. As a result, the bladder has a small capacity for urine and its contractions are unchecked. The result is urinary urgency and frequency, often accompanied by dribbling or incontinence. A person with MS may also have a flaccid bladder, which is an indication of a lesion in the reflex arc controlling bladder function. A flaccid bladder has a large capacity for urine because there is no sensation or desire to void, no pressure, and no pain. Generally, the patient has urinary retention, but urgency and frequency may also occur with this type of lesion. Another urinary problem is a combination of the previous two. Urinary problems cannot be adequately diagnosed and treated without urodynamic studies. Sexual dysfunction also occurs in many people with MS. Psychological erectile dysfunction may result from spinal cord involvement in men. Women may experience decreased libido, difficulty with orgasmic response, painful intercourse, and decreased vaginal lubrication. About half of people with MS experience some problems with cognitive function. For most people, the problems are difficulties with short-term memory, attention, information processing, planning, visual perception, and word finding. General intellect remains unchanged and intact, including long-term memory, conversational skills, and reading comprehension. On page 1384, Table 5811, this is a classification scheme with 4 primary patterns of MS, which has been developed based on the clinical course.
Since there's no specific diagnostic test for MS, the doctor must consider factors when diagnosing MS, including the history and physical, the patient's signs and symptoms, and the results of specific diagnostic tests. Some of the tests that the doctor may order are MRI, CBS fluid analysis, and evoked potential testing. MRI, they get the imaging of the brain and spinal cord. If the MRI shows plaque, inflammation, tissue breakdown, and destruction, then these would be signs and symptoms of MS. For the CBS fluid analysis, it's also referred to as a lumbar puncture or a spinal tap. For the evoked potential testing, this test can often reveal abnormalities in the brain and spinal cord and in the optic nerves of the eyes that other tests may not detect.
Okay, I'm already at the front.
Here is an MRI reading of a normal brain versus an MS brain. On the left side, there's a healthy brain, and on the right side, this is a brain with damage caused by MS. If you see these white spots, there's plaque and lesions on the brain. MRI does not use radiation. Instead, MRI uses magnetic fields and radio waves to measure the relative water content in tissues, both normal tissue and abnormal tissue in the body. Because the layer of myelin that protects the nerve cell fibers is fatty, it repels water. In the areas where the myelin has been damaged by MS, the fat is stripped away. With the fat gone, the area holds more water and shows up on an MRI scan as either a bright white spot or a darkened area depending on the type of scan that is used. So if you look at the picture on the right, you'll see those white spots, the plaque. That's where the water has been holding.
Because the MRI is particularly useful in detecting central nervous system demyelination, it is a powerful tool in helping to establish the diagnosis of MS. Please note that the MRI diagnostic test is the primary test the doctor uses to diagnose MS when in regards to the other two tests that we'll go over. Here's an example of the cerebrospinal fluid analysis results. If you go to the far left side, you'll see that there's no banding and it's just kind of like a blurry pink and white line. That's considered normal. Now, if you go to the far right two images, you'll see that there's these specific banding lines, and that is seen in MS patients. Cerebral spinal fluid analysis, it normally has elevated levels of immunoglobulin G antibodies and these bands, and occasionally there's also proteins that are the breakdown products of myelin. These findings indicate an abnormal immune response within the central nervous system, meaning that the body is producing an immune response against itself. An abnormal immune response in CSF is found in a number of other diseases, so this test is not specific for MS only. Also, some people with MS don't even show any CSF abnormalities. Therefore, CSF analysis by itself cannot confirm or rule out a diagnosis of MS. It must be part of the total clinical picture that takes into account the findings of the person's history and neurologic exams, as well as other diagnostic procedures. That's why earlier we were saying that the MRI is the primary test the doctors use to diagnose MS. On this slide, we'll go over evoked potential testing results. There's actually 3 types of evoked potential tests, but the doctors only consider the visual evoked potentials test because it's more accurate in regards to MS. If you look at the bottom picture of the gentleman staring at the screen, this is actually what the patient does to complete the visual evoked potential test. The patient sits before a screen on which an alternating checkerboard pattern is displayed. The test is used to identify impaired transmission along the optic nerve pathways, which is a fairly common early finding in MS. If you look at the top picture, you'll see a normal reading versus an abnormal reading. And if you look at the picture on the right, that is the pathway that it travels for a normal reading. The results of the VEP test are interpreted by a neurologist with a specialized training in the use of these tests. Despite the fact that the VEPs are used to help make a diagnosis of MS, other conditions can also produce abnormal results, so this test is not specific for MS. The information the test provides needs to be considered along with other laboratory and clinical information before a diagnosis of MS can be made.
Collaborative care. Management of MS falls into 5 categories. Category 1 is treatment of relapses. This includes exacerbations, flare-ups, and attacks that last less than 24 hours. Category 2 is symptom management. Category 3 is disease modification. Category 4 is rehabilitation, which helps to maintain or improve overall function. And Category 5 is psychosocial support for the patient and their family or caregiver. The first 3 categories are typically handled with medication therapy. Here is what your typical treatment team for MS would look like. As you can see, it's extensive and ranges from specialty doctors to therapists, pharmacists, and nurses. Drug therapy for disease modification consists of immunomodulators, also known as receptor modulators, which are used for patients with relapsing forms of MS or MS patients who have experienced a first clinical episode and have an MRI result consistent with the disease. They help to slow the accumulation of physical disability and decrease the frequency of clinical exacerbations by modifying the immune process. Examples are your interferon beta 1A and interferon beta 1B, glycimeter acetate, and teriflunomide. You will want to teach your patient on how to perform self-injections and site rotations. Let them know that flu-like symptoms are a common side effect after initial dose treatment and can be treated with over-the-counter acetaminophen or NSAIDs. And with most of these medications, they must wear sunscreen and protective clothing when exposed to the sun. Immunosuppressants are used for secondary chronic progressive relapsing MS. They work by suppressing the immune system's reactions. Examples are mitraxatone and dimethylfuramate. You will want to teach your patient to report side effects. Medication may cause hair loss and may cause urine or sclera to turn a bluish green, and they should avoid contact with the skin on the solution form. Your sphygosine 1 phosphate receptor modulators are a class of drugs that possess a unique mechanism of action as disease-modifying therapy for MS. They work as a binding agent that decrease migration of lymphocytes into the peripheral blood and CNS. Examples of this drug is the fingolimod. You will want to educate your patient to report side effects such as jaundice, nausea, vomiting, abdominal pain, confusion, loss of vision, and dyspnea. Advise them they might need to monitor their blood pressure regularly. They should avoid pregnancy, and if they miss a dose, contact the physician prior to giving their next dose. Your monoclonal antibodies work by targeting lymphocyte migration across the blood-brain barrier. Examples are natalizumab, altazumab, and daclizumab. You will want to teach your patient to report side effects such as jaundice, lymphadenopathy, colitis, and neutropenia, and advise them they should avoid pregnancy. Drug therapy for managing exacerbations consists of corticosteroids, which are a component of the hypothalamic pituitary adrenal axis, and they modulate the immune's response and reduce inflammation and expedite recovery from acute exacerbations. Examples are your ACTH, prednisone, and methylprednisone. You will want to teach your patient to maintain a low-salt diet, that they should not abruptly stop these medications. Be aware of drug-to-drug interactions. These medications may have effects on body image such as weight gain, and they should avoid crowds or people with known infections as this medication can weaken the immune system. Here are some nursing interventions when dealing with drug therapy. A few that I would like to point out is some of these medications require monitoring of eyes and nose and daily weights. It may cause hepatotoxicity, so monitor your LFTs as well as your BMP, CABC, UA, and UA microalbumin. They may require telemonitoring. Live automated vaccines increase the risk of an infection and may worsen anemia, neutropenia, and thrombocytopenia. And the patients must have a negative TB test prior to starting, and patients with active latent TB should be treated for TB prior to starting drug therapy. Other forms of MS treatment consist of physical therapy, which relieves spasticity, increase coordination, and train the patient to substitute unaffected muscles for impaired ones. Occupational therapy, which teaches alternate ways to perform tasks and introduce special equipment to aid in the signs and symptoms. And speech therapy, which teaches alternate positions while eating, oral exercises, and voice training. Nutritional therapy has shown to help with the signs and symptoms of MS and include taking megavitamins such as vitamin D, eating a low-fat, gluten-free, high-protein diet full of fresh fruits and vegetables. Your psychosocial therapy provides supportive disease-related education. It can be group or individual and teaches coping skills related to symptoms of MS. It addresses depression, provides family interventions, and gives the patient connection to available resources. Here are some nursing diagnoses for MS. Your patient might have fatigue, self-care deficit, powerlessness or hopelessness, disturbed self-esteem related to altered body image, risk for infection, impaired urinary elimination, risk for caregiver role strain, and risk for injury.